tonight, but our focus is going to be on this fun journey that we are all on. Well, maybe we're not all on it. I'm on it, so I'm just assuming everybody else is on it, about perimenopause. But first, let's hear from the panel. We're going to use our little tiny mic. So tell us who you are, where you work, and what your maybe like what's top of mind right now about perimenopause, and then we'll get into some questions. Audience, please save your questions. We do want to hear from you. So we're going to cover a lot of things that we think you want to hear about, but then we actually want to hear what you want to hear about, but it will be interactive. So I might be asking your thoughts about some of these things. So stay tuned. And if you saw the documentary, great. If you didn't, don't worry. We're going to talk about all the stuff. So you can still go home and watch the rest of it later.
All right. Hi, everyone. Good to see everyone. I think I might be the elder stateswoman in the room here, but proud to represent. So my name is, again, Kathy King. I am an OBGYN. I've been doing this gig for 25 years. I am based in Milwaukee. I'm on faculty at the Medical College of Wisconsin, and now primarily spend about 100% of my clinical time at Planned Parenthood of Wisconsin now. I in the ellipse, and I'll just be brief, of my career, I finished residency. Medicine was like a second career thing for me in 2001, and I saw the Women's Health Initiative study hit in 2002, which we'll talk about, which would put like the kibosh on menopausal care in this country. So I'm just really excited now that we are emerging out of that black hole, and that these services are once again going to be available to people who truly will benefit from it. So hopefully we can talk about all that today.
Hi, I'm Heidi Warner. I am a family medicine physician at Amplify in Onalaska. I primarily do full spectrum family medicine, but I have a special emphasis in midlife women's health, specifically around perimenopause and menopause. I have a MSCP, so that's the Menopause Society certified provider. And anyways, I love all things related to menopause and perimenopause, although actually I have a special interest in sexual medicine as well. So I do some work with the International Society for the Study of Women's Sexual Health as well. And that's my passions.
I'm Annalise Wilhelm. I'm a family nurse practitioner, and I practice currently at Viaro Health in La Crosse, which is a direct primary care family practice clinic. My background is in primary care, and then also formerly Planned Parenthood nurse practitioner. My journey to treating perimenopause wasn't like a direct line. At first, I used to just cringe and be like, I don't know how to do this. And actually, it's one of my favorite things to talk about now. I really am passionate about metabolic health. So, I'm fortunate to get to see the whole picture, not only some of these obvious symptoms of perimenopause, but diving a little bit deeper for full spectrum health throughout the lifespan.
Hi, everyone. I'm Ashley Sapieha. I am a women's health nurse practitioner. I have my certification as well for women's midlife care from NAMS. My background is originally in reproductive endocrinology, and then I worked at Planned Parenthood of La Crosse until October of last year, when I transitioned to working for MIDI, which is a women's midlife telehealth provider service. I serve patients in Minnesota and Wisconsin, and I truly started working specifically in women's midlife care because I watched my mom suffer for a really long time because no one knew that perimenopause could last for 10 years or longer. And no one knew that there were things outside of hot flashes and night sweats that happened because of perimenopause. So she was really the cornerstone of me diving into reproductive endocrinology, as well as now serving midlife women.
Hi, everyone. My name is Christine Ammerman. I am the center manager at Planned Parenthood of La Crosse. I have been working in reproductive healthcare in that clinic location for almost 15 years now. And I'm not a provider, but I did graduate from UW La Crosse with my bachelor's in community health education.
We'll just hand this funny little mic around so that our online friends can hear us. Dr. King, can you just start us out by just laying the groundwork? I think we all know, but I don't want to make any assumptions. Just what is perimenopause? What is menopause? What's the difference? And when do you feel like people know what it is, or are they coming to you with just like, I don't know what any of this is? That's kind of a 25-part question. And the way that we'll do this, I do have some questions for each of you, but if you feel like something was missing or you want to add something, just jump in and we'll try to cover a lot.
All right. I'm going to start in the middle and then I'm going to work around your question. So menopause. Menopause is one day in your life when you realize that you have not had, if you're someone who's been having regular menstrual periods. That's the other part. It's not always easy to tell. But if you're someone who was having periods and you realize it's been 12 months since your last menstrual period, that day you are in menopause. And from that day forward, you are in postmenopause. And now that we are living longer, it's estimated that we will spend probably 40% of our life in that postmenopausal phase. That's a good chunk of time, right? And all of us, I think our goal is to lead healthy, vibrant, productive lives and not become the frail person who falls down and breaks their hip, right? And all the negativity that goes with that. Perimenopause is just this general term of around the time of menopause. And we know, if the average age of menopause is at 51, perimenopause can last up to 10 years, right? And if the age spectrum of menopause on average can be anywhere from 45 to 56, if you're biologically programmed that your ovaries are going to run out of all those little primordial follicles at 45, you could be in your mid to late 30s having symptoms of perimenopause. And I think what women, and I use women, but people with ovaries who can go through this transition have been dismissed is I'm still having regular periods and be told, well, you can't be in perimenopause because you're still having regular periods, right? And so it's really this transition phase where, and everyone's journey is different from that. I think a lot of people come in just saying, I don't feel like myself. Like, this is not me. I don't recognize me. I walk into the room and I don't remember why I walked there. I can't think of a word. I'm blowing up at my kids and I don't know why, because I'm so freaking irritable and having these mood swings. What the heck is going on? So that's my little spiel.
Let me ask all of you, this came up in the documentary. How many people watched the documentary? Awesome. If you didn't, don't worry. So in the documentary, they talked about how little training there is for any of these symptoms or what you're supposed to do as a provider. So let me just go down the line and ask each of you in your different roles, what kind of training did you get for this when you were going to med school, going to school for community health education, whatever? Did you get any kind of training? How long was it? How extensive? Just down the line.
Med school, don't remember much of anything. Went to UW-Madison, but that was a long time ago. And so my OBGYN residency was from 97 to 2001. And we actually talked about menopause a lot. And at the time, it was the thinking based on nurses study and all these other kind of longitudinal observation studies, that hormone therapy was a good thing for you and was cardioprotective, helped you reduce your risk of osteoporotic fracture, and it was a good thing. And one of my mentors on faculty was part of the Women's Health Initiative, and I thought that was so cool at the time, and that this was an amazing study, this randomized controlled trial. Little did I know what would become of that. Yeah, I'll stop there.
So interestingly enough, I actually think I got more education on this than most providers did in medical school. So one of the things they talk about is how we were taught almost nothing. But I do remember at least one lecture in medical school where we talked about the Women's Health Initiative and the post hoc analyses that had been done and some of their safety as long as we used menopause hormone therapy within the appropriate time windows. So I actually already had a little tiny lecture. Maybe it was a whole whopping one day, but hey, it was an hour or something that in medical school. And then I did my residency from 2015 to 2018. And I remember having a patient that was suffering immensely. And I was like, there has to be something that we can do to help this lovely lady. And so I had one of my attendings in residency was like, well, you can actually give her hormones. And so I actually did prescribe oral hormone therapy back as a resident and proceeded to do a little bit of that up until I did extensive training over the last couple of years. But
in NP school, we did get training, but probably a lecture. I've done a lot of my own learning by seeking out mentors, seeking out conferences, and just continuing to learn every day and even learning from my patients.
In my doctoral program, we actually had a lot of focus time that was focused on women's midlife health, not only, hormonal changes, but metabolic changes, cardiovascular changes. I think I had the privilege of being in a specialized program where I was in a women's health doctoral program. So out of my 4 years, we did about a month each semester that I had didactic study on midlife changes. And then after I graduated, I did a training with ASRM on when I was working in reproductive endocrinology. And there was a 10-hour lecture series specifically on the changes that happen in perimenopause and postmenopause. And then recently, since starting my new role, we do continuing education for an hour every week, led by, either our colleagues or by outside educators. So I feel very privileged to have not only that foundational education, but also that continuing education for new and emerging information.
I recall nothing. From undergrad, I was in college 2006 to 2011. We did not speak about menopause in community health education.
That was so dramatic. We did not speak about it. And I think that was kind of like the norm for a long time. Right before the session, Dr. King and I were talking about just this explosion of information that's happening right now around this issue, which it's going to look different in 10, 20, 30 years when it's kind of calmed down and whatever. But we're in just sort of a very interesting time where everyone's talking about it, which is good. It's better than not talking about it, right? Let me do a little bit of an interactive thing with the audience. You don't have to answer if you don't want to, as we get into the next section of like some of the symptoms and the treatment. So as I disclosed, I am on the perimenopause journey, feeling a lot of things. Not all of them great, most of them not great. So let's just, if you feel like disclosing, raise your hand if you are on this journey currently. And I'm going to list some symptoms. Raise your hand if you've had these symptoms once, twice, many times, so that we can kind of see. And then if I don't mention one of the symptoms, I want you to tell us what your symptom is, if you want to. How many of you have had hot flashes? She was raising her hand before I even asked the question. She's like, yes, I have. Insomnia. Brain fog, irritability or moodiness, Depression, feeling itchy in ways you never have before. Ears, yes, I heard someone say that in the back. What about this frozen shoulder? Okay, we got a couple frozen shoulders. Burning sensation in your mouth, or like a weird burning taste in your mouth. I had that one. That was so weird. Night sweats. Yes, a lot of night sweating people. Incontinence. It's happened to me.
Wait, you mean like when I sneeze, or like when I waited too long and I have to like go like this and then I close my eyes and I have to like breathe in and go back up?
I think that's, yes, it could be. I think I could mean that, yeah. Vaginal dryness. Exhaustion, more than normal. What about acne when you haven't had it for a long time? Okay. What about changes in your hair? Okay. Facial hair when you haven't had it before? Okay. I am loving watching your faces as you answer. Weight gain. Yeah, this is so fun. Bloating. Yep. What about like just wild changes in your period whenever you do get your period? All right. Any symptoms that I didn't name that you have had that you just want to share? You can yell it out.
What about like tired eyes?
Tired eyes. Okay.
One thing I didn't realize was a symptom until I watched the documentary was pain with intercourse. I just thought that, well, anyway, I didn't realize that was a thing. And
Yeah.
It was related to something real and not just, other stuff. So.
Yeah. How many of you felt some rage when you were just listening to the men on the documentary? That's a symptom. Any other joint aches? Yes. Yep. Anything else?
I don't know if it falls into depression, but you just don't care.
Yeah. I just don't care. IDGAF, yeah. I don't know. Is that perimenopause or just like as we get older, we just care a little less? Okay. Losing some niceness.
I'm the kindest person that I know. Well, I like to be kind. It makes me feel better to say the nice thing, and it's never not genuine. And for a long time, I do the things. I did change my birth control. Those things worked for me. I didn't change my eating. I did do a lot of the things you guys are going to say. I do drink a lot of I do all the things. It's a lot of things. It takes a lot of time, and it's not always working. When I have all the things, I'm not very old yet, but that's cool. Life is long if we're lucky, right? But lost it. See, there's my train. I noticed that I stopped masking. And my ADD and my ADHD came out, and then I also was like diagnosed. We put it together. All my kids that came out of my womb, are all on the spectrum, and the only common denominator between like 2 and 1 is me, and they're all on the spectrum. So with all my tendencies, and I feel better, But like putting all that stuff together, the weight that women have to like bear, just like knowing allowed me. I have freedom in the fact that my F's lowered the moment that my estrogen did too. And I am a literal human being, so I'm going with it.
Yeah, there are a lot of like overlapping symptoms that leaves you wondering, is this perimenopause or something else? So Dr. Warner, when people come to you with this list, because it's not usually just one thing, how do you determine, is this perimenopause or something else?
Oftentimes, it can be really challenging to tell. So we'll take into account the standard things that I look at about their age and their menstrual cycles, and those can give me a little bit of an idea. But if we are outside of those typical windows, then a lot of times I just listen to my patient, and if the symptoms add up, then maybe it is perimenopause, and we could always at least try to treat it and see what happens. If the patient gets better when I treat perimenopause, then it was probably perimenopause. And if we tried all of the typical things I would do and it doesn't get better in 3 to 6 months, then maybe we need to go looking for something else. And maybe it is also multifactorial. We do a lot more ADHD evaluations that we hinted at back there and things. So see a lot of things like that in this time frame too.
Do you, Annalise, do you want to share with us just what are people saying to you when they come to you to talk about perimenopause?
Oftentimes they come in and sometimes they're embarrassed. They don't know how to open the conversation. I hear a lot, I just don't feel like myself. I feel crazy. Something's wrong with me. And along with Dr. Warner, I just simply listen. You know, some people think they have to prove something to me. They have to prove how bad they feel. No, I am here to take care of you. I believe you. Like, we need to believe women. So every symptom that we talked about and then some is usually what people come in, but usually it's leading with just maybe they snapped at somebody at their kid's basketball game, or their sex life is lacking, or they have tremendous brain fog and they're just not feeling like themselves. But I would say the most common symptom I hear in my clinic is, I just don't feel like myself and I don't know what's wrong.
Ashley, let me ask you, so I think what I saw in the documentary is that this is very individualized. Like, there's not just a quick fix for everyone. It's like, you know, depending on what your diet is, what your activity level, like everything's different. So when someone comes to you and just says, help me fix my perimenopausal symptoms, how are you trying to figure out what to do to help them?
Yeah. So, I mean, a lot of my patients are like, well, my friend is on this patch. Can I get that? And I'm like, maybe. Because it's not one size fits all. And I always tell my patients too that it's not even one size fits all for one person for the rest of their journey. So, you know, when we're doing an initial consultation, you know, a lot of it is going to be, you know, when did these symptoms start? Have they gotten worse? Have you changed anything in your life? Talking about their earlier menstrual cycles. Have you had irregular or regularly irregular periods for most of your adult life? Has that changed? Has your circumstances, your job, your marital status, your relationships, whatever? Because we also can't discount that most of these symptoms are also going to be multifactorial. So we can't just point to it and say, here's a 0.075 milligram estradiol patch, slap that on, change it twice a week, and you'll feel better. So for a lot of people, it's going to be some trial and error and some really custom tailoring how we treat symptoms. Some of my patients are cancer survivors, so we have to talk about, you know, survivorship and what that looks like for them. What kind of cancer have you had? Is it estrogen or progesterone receptive? Are we looking at, you know, familial history? So there's so many factors that go into it that it really does need to be individualized from person to person. And we need to look at the big picture, you know, what their diet looks like. Are you having any deficiencies in vitamins or micronutrients? Are you ferritin or iron deficient? Because some of the symptoms that come along with perimenopause don't get better with HRT because they're underlying from something else.
Christine, we have been offering these services for a while, but most people don't know that we do that. I see people in the community all the time that regularly tell me like, oh, I love you guys, but I already have my kids, I don't need you. So do you feel like, as we've been kind of pushing this service a little more, do people know we do this? What are you hearing when people are coming into the clinic?
I personally feel in this area that no, it is not well known. I think we could do a better job at getting the word out more, and word of mouth is very helpful. And we offer in-person and virtual visits. So I think we're not hearing often from patients that they are aware. They'll come in for a totally different service, and then our provider will mention something in it, and they're like, oh, really? And then we'll be able to schedule them for a return visit to discuss other concerns.
Thank you. Let me, I'll cover up a little mic here. Once again, just want to ground us a little bit. And Dr. King, can you tell us what is HRT and how do you decide when to go that route with a patient?
That's a big question. So language. So when I was training, it's hormone replacement therapy, and a lot of people still use hormone replacement therapy. There was a time, and I can't remember if that was Menopause Society or who came out with that, was saying we should stop using HRT because it's medicalizing this natural life stage. And so menopausal hormone therapy would be the acceptable thing, but they're exactly the same thing. So when we're talking about hormone therapy, there's basically, right, 3 hormones, right? So we're talking about estrogen, and more, I think most people are gravitating towards, our preference is using bioidentical or body identical hormones when we're using menopausal hormone therapy. And there's always going to be exceptions because there's so many different products for us to choose from, and not everything works for everyone. But I would say our first line for folks who are candidates, and most people are actually candidates for hormone therapy. There are actually very few contraindications, and I think that's a big myth. I saw like a question of, well, I'm not a candidate for hormone therapy, so what can I use? And I'm like, most people are. There are a few pretty hard, fast, like, nope. But most people are candidates. So estrogen, 17 beta estradiol, that's what our ovaries are making during our reproductive years. Estradiol is the main reproductive estrogen that we live in and use. Progesterone, right? So progesterone, again, is kind of predominates in the second part of our menstrual cycle. So if we ovulate, little corpus luteum makes progesterone, and that's getting the uterine lining ready for, maybe I'm going to get pregnant this month, and oh, no, that didn't happen, and that little thing shrivels up, goes away, progesterone levels drop, and you get your period. And now we tend to use micronized progesterone, bioidentical, body identical progesterone. The things briefly that gave hormones a bad rap was in this Women's Health Initiative trial, where they did not use the bioidentical, body identical hormones. They used conjugated equine estrogen, which is truly the only natural estrogen product, but it's derived from pregnant mare horses. That's where it comes from. But it's binding to that estrogen. There's actually 2 estrogen receptors. It's binding to it, but not quite fitting. And it just has a little bit different properties. But we still know from the WHI, especially in the estrogen alone arm of it, that it still had really good effects. Estrogen, our usual go-to is to do it transdermally because it kind of has eliminated those concerns about, I'm going to get a blood clot, I'm going to get a stroke, right? Because if you don't have to metabolize something through your liver, you're going to not make all these procoagulant things that are going to put you at increased risk for clotting. So we've got estradiol, we've got progesterone, and then the new kid on the block, which we've been ignoring for a long period of time, is testosterone. And yes, women do have testosterone, right? And so what is happening through our lives, right, is, testosterone actually just kind of slowly declines over the lifespan. And actually, when one starts getting older, it actually might go up a little bit. But testosterone, we still have testosterone. Some is made by the ovary, some is made by our adrenal gland, and then some just gets peripherally converted to testosterone. So that's when we are talking about hormone therapy, those are the 3 hormones. And I'm definitely seeing a bigger shift, and I think it's because of social media and all this, of women coming in and saying, I want, my 0.05 milligram estradiol patch, I want my micronized progesterone, and I want my testosterone. And I'm kind of a person of the school of like stacking things. So I know what you're reacting to what. And so I'm like, sometimes delayed gratification, we'll get there. But especially in perimenopause, it's a journey, man. And it's a lot of trial and error because menopause is easy. Like, ovaries, shut down, steady state, the first years, things change, but it's a little bit more of a steady state. Whereas perimenopause, from 1 month to the next, your hormones are up, they're down, your FSH level is normal, it's abnormal, your estradiol is like, boop, whoa, and it's these wild fluctuations in hormones that are this roller coaster ride of perimenopause. And when do I use them? When people are symptomatic and suffering, and I think that they could benefit from them.
I love that answer. Now, I'm going to open this up to whoever. People want to know how perimenopause is affecting other things with their health. So how is it affecting their heart health? How's it affecting bone density? How do you figure out when talking to patients, it's so overwhelming, all the changes they're going through, but what about the other things that are happening in their body?
So that's one of my favorite things to talk about with my patients is that I go through the HPO axis, right? Your hypothalamus, your anterior pituitary, and your ovaries, and they're a fun little cycle that during your prime reproductive years, they're all besties. They're in a group chat, and then they go no contact, right? So we have to think about the fact that they are no longer upregulating each other like they used to. And so now, not only is it a pregnancy and period problem, it's your whole body. And so we have to think about all of the estrogen receptive tissues, which is all of them. And so not only is it your periods are going to get weird, you're going to get moody, you're going to have new onset or worsening anxiety, your face is going to break out, your skin's going to get dry, your ears are going to itch in the middle of the night. Also, your bones are going to start losing some density because your osteoclasts and your osteoblasts, which are your bone building and bone breaking cells, aren't doing the same thing that they used to. And so that's why women in midlife and aging women are at such a higher predisposition for morbidity and mortality from fragility fractures. How many people have a grandfather who broke their hip? Not very many. But we have so many women who have hospitalization and really significant, negative outcomes after fragility fractures. So that's one. I think that the biggest thing that we can do is start DEXA scans sooner. So a DEXA scan is basically looking at the bone density of a couple of major areas. So your lumbar spine, the upper part of your femur, which is that big bone in the top of your leg, and then sometimes the wrist. And that can give us a good insight for a baseline, as well as if, you're at...
Have your attention, please. The library will be closing in 15 minutes. If you have materials to check out or need a library card, please go to the welcome desk now. In preparation for closing, public restrooms will be closing in 5 minutes. If you need to use the restroom, do so now.
And if you're at risk for, those things in the future. And then the other big thing is women come to me and they say, I have gained 15 pounds all around my belly and my hips. I feel like I'm wearing an inner tube all the time. None of my pants fit and it sucks. Can I have a GLP-1? And my answer is maybe, but also let's talk about how your metabolic health changes because of perimenopause. And we have to remember that the pancreas, surprise, has an estrogen receptive pathway. And so you have to think about how your body metabolizes the things that it takes in. A lot of women, most women, are going to develop some level of insulin resistance in midlife because of perimenopause. And so you're going to get that hormonal weight gain around your belly that doesn't go away no matter how much you exercise and how many salads you eat.
So I have a urgent question to ask the audience. Okay, go ahead.
I just asked if we were.
I didn't get to ask a question.
We are going to, but I'll let you jump in if it's urgent.
Yeah, well, actually, I have more than one, but so I work in healthcare. I watched the 4 parts of the documentary, and I know how difficult it can be to be competent and confident in talking with a provider. So I have a provider in Onalaska with Amplify, where I'm also employed, and have asked about some of these things and have what I have perceived as being shot down numerous times. And one of the things that I am very aware of also is what kind of appointment do I ask for so that some type of insurance could possibly cover it? Because my spouse is a medical assistant, so he's been trying to help me think through this, which I appreciate, because you have to know what kind of appointment to ask for so that, anyways, I know a lot. I guess, about healthcare.
Do you mind if I take this one? Can I start?
Well, I have a question though.
Okay.
So, or I want to give you like
Dr. Warner.
my here. So what kind of question do I ask for? The other thing is that my provider said that if we did any kind of like a hormone test, it would not be relevant because our hormones are changing all the time. Yet in this film, that was a part of the diagnostic that was happening. And so I guess I'm just, trying to figure out like how much more confidence and like courage and bravery can I have without like feeling like I'm just kind of like being met. Because like, is my psychiatrist someone that should be on board with this? Because they're the one prescribing me medicine so I can sleep at night.
Yeah.
All those,
Okay.
all the things. Like,
All right. I'll take this one as the Amplify lady. Okay. So, number one, I'm hoping that I'm changing that. So if you call Amplify Family Medicine, you will probably get an appointment with me. If you tell them that you are having perimenopause or menopause symptoms, my schedulers are pretty darn good that they will probably just stick you on my schedule because I have the most expertise in this area. Okay. So if you try to book it online, it may not happen, but if you actually call the schedulers, they will probably put you with me. Okay. So, but that being said, I think the first thing to do is don't bring it up at your wellness exam, or at least do not expect that you're going to get a full assessment of this at your wellness exam, okay? So our annual wellness exams, I know that insurance and the news and like the media are just like, bring a list of all the things you want to talk about. I have a very limited amount of time at a wellness exam, and I have an agenda when I walk into that wellness exam. I have that I must refill your chronic medications. I have to do all your cancer screenings. I've got to get your metabolic screenings done. I have a list of things. And so perimenopause is, I get the same amount of time for a perimenopause visit as I do for a wellness visit. So I get an entire 40 minutes where that is what I'm going to talk about is perimenopause. I don't have time to talk about perimenopause in the middle of a 40-minute wellness exam when I was supposed to do those other 10 things as well. So number one is just tell us ahead of time what you're looking for, and then we will try to get you to the right appointment time. Okay. So yes. So, yep. So then, I think it's interesting is we went down this line and she asked us like, how much training have we had in it? And you got a very different answer than if you had asked any other like primary care panel about how much menopause training they had had. We all have a fair amount. Most of our colleagues have zero. Okay. Yes. I am trying to advocate.
Attention, please. The library will be closing in 10 minutes.
Testing our perimenopause.
Automatically shut down in 5 minutes.
Yeah.
Please print or save to avoid losing your words.
So I'm definitely trying to advocate for more knowledge and things like that in the space. I have literally just last week, I gave a talk to the family medicine residency, teaching them all about menopause and hormone therapy. I've already been asked to do 2 presentations for continuing medical education on this topic. So we will continue to get better. This is an evolving space, and I promise that. And you're right, many women have felt like they've been the term they use is gaslighting, where you just feel like you haven't been heard. And so, going back and saying, hey, it seems like this is something that's really bothering me, and I am wondering if you have anyone who has expertise in this area, and then they could get you referred on. Again, it will potentially be myself. It'll put at Amplify, it'll probably be one of like 4 providers that have MSCP certifications, myself in family medicine, Dr. Rose Wilbrinks in Sparta in family med, and then there's 2 OBGYN providers as well, okay? So they'll try to get you with someone there. The whole question about labs, I think that is a whole different discussion. Do you have a plan to talk about labs at some point?
We can talk about, did you want to say something?
I was going to say,
I was just going to say that I'm sorry that you're having that experience, and I would agree. Just continue to advocate for yourself and find a provider that will listen to you and take you seriously. And oftentimes I'm seeing this a lot as a primary care provider, where women are coming to me for specialty perimenopause and menopause care, even though they have a PCP somewhere else. And that's a little uncomfortable for me, because as a PCP, I'm used to kind of managing that whole spectrum. I'm like, oh, am I kind of stepping on toes here? So as Dr. Warner said, I would call back specifically, and it's okay to change providers if you feel like you're not getting what you want. We're not offended by that. You have to have that partnership that you're comfortable with.
Also, Planned Parenthood such private insurance.
So does Medi.
So does VRO.
Do we
Many
know-
places.
Yes, we do want people to know that at Planned Parenthood, you can come see us with your commercial insurance or without, and we can help you. So we do want people to know. I just saw somebody online in Colorado, a friend of mine, who was like, I've spent 3 years trying to get my doctor to take me seriously, and I finally got my HRT. And I'm like, you should have gone to Planned Parenthood, but you know, she finally got what she needed. It shouldn't take that long. What about the labs question?
Does anyone else want to take that,
Do
or
you want to talk about it?
Dr.
Yeah. All right. Tricky in perimenopause, right? Because when we check labs, when a person is in perimenopause, say you're coming into me and saying, I'm having all these symptoms, my periods are becoming really irregular. My cycle used to be 28, 30 days, and now I'm like 21 days and 47 days, and they're just all over the place. And I really want my hormones checked. And I'm like, I could do that, but what it's telling me is this is your hormone profile on this particular day, right? And so say on that particular day, I check your hormones and your FSH comes back at 20 and your estradiol is 162. And I don't know, I'll check a TSH, and I don't really check LHs, but I'm more so,
normal lab results?
These are normal labs, okay? Versus if the labs were off and now the FSH is in a menopausal range and the estradiol is low normal, I'm not going to change how I'm going to treat you based on that lab. I'm going to sit down with you and talk about your entire medical profile, lifestyle. Are you a smoker? Do you drink alcohol? Like, take everything into consideration. I'm big into lifestyle medicine as well, right? Holistic, global, because I'm not going to just make everything perfect with the hormone. And so if we're looking at overall health, metabolic health is, we've touched on overall wellness, it's lifestyle changes as well as hormone therapy for a lot of people. And so labs alone, sometimes they're helpful, right? So we'll have people who had a hysterectomy. We have no menstrual history. I don't know where you're at hormonally. You've had a hormonal IUD for 15 years and you've not had a period for 15 years and you're having all these symptoms. And and there are some times where I'm like, I don't know, are you perimenopausal? I don't know. And so sometimes, yes, I will check labs, but for the majority of times, it doesn't change how I'm going to manage people per se. And the one thing I would just tell people to be cautious of is I see a lot of people are getting into this space of treating perimenopause and menopause. There's a lot of money to be made in this space too. And I'm afraid some people are coming at this from a money-making perspective. And I think there's also a lot of people who are getting very, 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 very frequent lab testing and a lot of interesting lab panels delving into these Dutch panels.
I see this a lot where people will come from outside, almost a la carte labs, and then they're expecting me that doesn't have a relationship with them to interpret them. And that's really difficult because, like we've all said, I'm here to take care of you as the whole person. So I can't get all that information I need just from these labs that I might not have even ordered.
Yeah. So there's a lot of stuff being done out there that actually doesn't have a lot of clinical relevance. And it's just getting people, like a Dutch panel is like $700, like pop. And most of this is concierge, you're paying out of pocket, and people are just spending money and spending money and spending money. And I don't think this is like evidence-based care at all.
So whenever it was brought up in the series, I guess I paid attention to that because I thought I had heard my provider say that was not going to be relevant.
Yeah.
But then it was a topic there that they were like, hey, this is really low. So
I did notice they were going to med spas often. So a lot of the facilities in the video I was inferring that were standalone concierge, private practice, and or med spas. So I've also worked in the med spa space, and I think it's really great for some things, but there is a lot of money to be made in the supplement industry and the hormone industry, and they're making money by checking those labs, and then they're making money by selling the supplements and the hormones right from their clinic.
I was going to jump in too and say that like we don't endorse every single thing that was in the documentary. It's a good conversation starter. I was confused at how many providers they were going to, and then I'm like, are they talking to each other? Like, it seems like every minute they're going to a different person for a different thing. I think the other thing I want to say is that you shouldn't have to be mustering up this courage and all this this is your body. So to Annalisa's point, if you're not getting the attention that you need from your provider, then you got to find a new one. And it shouldn't, I do think we've all had these experiences of feeling dismissed or feeling shame or feeling confused or feeling scared to even ask our doctor something because maybe it's embarrassing or maybe we don't need it. I mean, it does get intimidating because we think like, they know everything, and so what if they say no or whatever? But I think that what we are hoping that people can feel is some sense of like advocacy for themselves. And if you're not getting what you want, then keep looking until you find that, which I know is hard because it is hard to get on a schedule, especially if you're going through your commercial insurance. So again, got to plug Planned Parenthood, come in and see us. Yes, we've got our expert here who's local. So, that is hard to do though. That's a very real thing. And that is part of this whole issue is that because we've been dismissed for so long or because women's health has been on the back burner for so long, it is hard to go in there and be like, hey, like I actually need to take your time. My doctor was like, we're not 18 anymore. I'm like, yeah, I'm very aware that I'm not 18 anymore. Totally aware of that. I don't need you to tell me that. Like, that was ridiculous. So it does happen, and we all have these stories. So I have a couple more questions, and then I want to open it up to you all. I have heard from people that I know that once you hit menopause, it's like, oh my God, everything gets so much better. Is that true?
No. So it's not a hard no, but we have to think about what's actually happening, right? So as Dr. King was talking about earlier, we're thinking about what your ovaries are doing because they're the driving factor of perimenopause and menopause. You have these little dots on your ovaries called follicles every month. When you're in, your prime reproductive years, late teens to mid 30s, you're bringing up a group of those follicles. And usually one of them is going to mature and ovulate and maybe turn into a baby and maybe come out when your uterus is sloughing. But as you age, your ovaries age with you. You're born with all of the follicles you're ever going to have. And so every time that you have a menstrual cycle and you bring up this group of follicles, you're losing those. And so perimenopausal transition is truly just when you start having those irregularities month to month, where sometimes you have adequate follicular volume and sometimes you don't. And so when you're getting towards that later stage of perimenopause and into true menopause, that's when your ovaries are just saying good night and good luck forever. And so when you're thinking about perimenopause, we're thinking about those crazy fluctuations and how that follicular volume can change from month to month. When you hit true menopause, it is just the baseline deficiency, right? You're maybe making some, precursors to estradiol from other bodily tissues and your body's running on fumes, but you're not getting that good straight shot of the good stuff that your ovaries used to make. So you may have symptom improvement because you're not having these crazy fluctuations anymore, but you're still having baseline estrogen deficiency. And so some of those things are simply not going to go away.
Yeah. And I will say, being the human in this room that's been through the perimenopause, menopause, and now postmenopausal journey, and for those of you in perimenopause, personally speaking, for me, things got better in menopause. I came of perimenopause during the time where hormones were not a thing. So me being a physician, I had to beg and plead for my physician to put me on hormones. But I got him. I was like, I'm not leaving this office until you give me the hormones. Okay. And every year I'd come back. Are you sure you want to stop now? Because it was like, use the lowest dose for the shortest amount of time and get them off them as soon as possible, right? That was the thinking back then. But for, and I'll just speak personally, for me, I kind of it was a reckoning for me, that I was like, this is the time of life. Like, I was so busy taking care of everyone else, like, I got to start taking care of me, man. Yeah, right? Because all this stuff's happening in my body, and I want to thrive when I get older. I don't want to be that frail person, that sick person. And so, I really said, I have to get serious about stuff. So, I was on hormones, I'm on hormones, and been on hormones. I'm not on testosterone, but I'm on estradiol, progesterone, and vaginal estradiol. And as you get older, vaginal estradiol or vaginal DHA is your friend. And it's just not about sex, right? That's part of it, but it's just your whole vaginal, vulvar, bladder, urinary health benefits from it. Another big thing, bladder infections, especially when you get older, and if you get urosepsis, right? So fragility, bone fractures, urosepsis, as you get older, you want to do everything you can to prevent those bad things from happening. And then I think it's also just really important about looking at nutrition. As we get older, we lose muscle mass, and as we lose muscle mass, our metabolism slows. Whoa. And so, our diet has to change. So, you hear protein, but protein is really, really helpful to keep your muscle mass. And estradiol helps you keep your muscle mass, but you also have to start working at it. And so exercise is super important. Strength training is super duper important to keep your muscle mass up, to keep your bones strong. And so all these things get tied together. But perimenopause, even when I was on hormones, sucked. It really sucked. I will say that. It got better on hormones, but those hormonal fluctuations are rough. And so menopause, at least from my perspective and for me personally, things just got steadier. And it wasn't such a roller coaster ride, and the mood and the anxiety stuff got better.
Dr. King, would you say the brain fog improved post-menopause? We get that question.
Yes, absolutely. Yeah.
So there's hope.
Yeah. Except when I'm I don't do call anymore, but post-call, that was rough. But yes, that gets better too.
All right. I could keep going, but let me open it up to the audience and see what questions you all have. And then I have a couple more in case we don't cover them. But what do you want to know from this amazing panel of people up here who are here to help you? Yes, in the back.
Could I ask about the brain? So what is the estrogen doing to the brain that when you have these fluctuations that is affecting your memory or your just ability to function? What is it doing, I guess? What are we missing when we don't have it?
I missed the how in depth do you want?
So I have a background in neuroscience and just don't know a lot about how estrogen affects the neurons or what is happening, and you don't have to go into a huge amount of details. I'm super curious.
So in general, I think there's a lot that we're still learning in this space, and please correct me, any of you guys, if I'm get any of this wrong. But so there's actually a fair bit of research going on in the menopausal brain space, but we do know as we hinted at earlier, there are estrogen receptors everywhere. So there are a ton of estrogen receptors in the brain, and they probably do play a role in, number one, hot flashes. So hot flashes actually begin in the brain. They're actually related to estrogen receptors in the hypothalamus that are not that end up in when there's not estrogen, you get this increase in neurokinin, and then that interacts with these things that we call candid receptors. It's KND, little case Y. Not a board test. I promise, not a test question for any of you, only for me. And then that area interacts with the like temperature regulation zone in the brain. And so that's part of actually, like I say, where the hot flashes come from. And that's actually where some of these newer meds come from. So are things like Veoza and Linquit, which are our newest two menopause medications that are not hormonal. They actually worked on that neurokinin modulator system. Okay. So then in terms of like the mood symptoms, that I believe they think has something to do with the prefrontal cortex and the amygdala and the estrogen receptors in those areas. Causing some like increase like upregulation of the receptors in perimenopause, when I always analogize it to like begging. So you really, really, really want something and somebody keeps saying no. So you just keep putting more hands out and asking whether or not you're going to get any. And eventually when your mom tells you no enough times, you just give up and you put your hand down and you go away and say, I'm not going to get candy. That's kind of like what those receptors in the brain are doing. So in perimenopause, in this early menopausal transition, they're upregulating. And so they want estrogen and they're begging and begging. And then eventually, like 2 years after menopause, they tend to just kind of like fizzle out. And that's when people will tell us like the mood gets better, the brain fog gets better. So interestingly enough, hormone therapy, I find mixed results with the brain symptoms. But the good news is, regardless of whether or not your brain symptoms get better with hormone therapy, they tend to get better naturally in about 2 to 4 years. Yes, everybody hates me when I tell them that in the moment, but it does end. I don't know. Did I get all of that right? Halfway?
Basically, like, it's like you're on heroin and you took it away.
Yeah. Yes.
Yeah.
Yes.
It's like exactly the same. Okay, that helps me. Do you have a question, Myra? I do have a question. I just started hormone replacement. I'm a patch progesterone pill. Amazing. I feel like doing things again, being productive, finding joy in making sure my house is in order. Like I would sit on the couch and I could care less. I had your physique and I am the heaviest I've ever been. And our eating habits are quite healthy. And I don't budge at all in my weight. I struggle with physical activity after a car accident, so I have some problems there. But my second part of that question is the amount of marketing of supplements and fasting and like mushroom extracts. And I am just like, I don't know where to go. Like, I don't want to be this size. I'm so frustrated.
Everyone is trying to sell you something. And that's what I have to talk to my patients about so often, because they come in and they have a med list that is not a med list. It is a shopping list. It's literally 10, 12, 15 supplements that they're taking because someone on social media, some influencer who has some, brand or degree or whatever. I saw a chiropractor who was trying to market postmenopausal supplements. There's a time and a place. But a lot of these things are simply, like we were saying, in the med spa space, in the concierge medicine space, it's a lot of people trying to sell you things. And so I always go back to try and get as much from whole food sources as you can. If you can't get it from whole food sources, supplementation is fine, but make sure you're getting it from good sources. Protein and fiber are really the two big things that I always am going to harp on with all of my patients. Dr. Mary Claire Haver, which I think she was in the thing, she works with the company that I work with, and she's incredible. She has a secondary fellowship that she did in like nutrition medicine and whatever. And so she wrote a book called The Galveston Diet. Yes. And a lot of it is great, and a lot of it is a lot of work. I know that I, as a person, am not going to track every ounce of everything that I eat because that's not sustainable. So the biggest things that I'm always going to push are protein, fiber, and non-exercise activities of thermogenesis. So people are always harping on, do your 30 minutes, 5 days a week, get your heart rate up and sweat. And those things are great, right? That obviously is going to be good for you. However, we have to think about the other 23 and a half hours of the day when most Americans are very sedentary. Most people are doing work at a desk or, have very minimal movement. They're walking to their car and then they're walking to their office and then they're walking back to their car and then they're walking to their couch. And we know that when you have, very sedentary periods, your metabolism is just kind of slowly plummeting. That's why, the whole sitting is the new smoking thing came out. And no, I don't think that sitting is the new smoking, but there are some really significant health impacts, right? And so we know that for perimenopausal and menopausal women, because of the metabolic changes that happen, all of the things that change not only with insulin resistance developing, but also changes that happen in the microbiome in your gut, the changes of how you're able to process and metabolize certain foods that you eat. Like Dr. King was saying, it's super important to know that you have to change things with time because your body is not the same as it was when it was 30 years old or 20 years old or whatever. Because like you, so many of my patients say, I used to be 110 pounds soaking wet and I didn't change anything about my life, but now I'm here and I don't feel comfortable in my body. And so somehow it became very taboo to talk about weight and we made it a moral issue. And so much of social media is very unfortunately now trending back towards the early 2000s and this hyper thin whatever. My biggest thing for my patients is always going to be, what's your intrinsic health look like? It's important for you to feel good in your body, but it's also important for your body to feel good. So, long answer, longer, focusing on those things that you can control. Consistency is always going to be more important than trying to overhaul your whole life. And if you need extra helpers like a GLP or something from the outside to help fix any metabolic dysfunction, that's not a moral failing. It's just helping your body.
And I did recently ask when I started this hormone replacement therapy, here's my brain fog, word finding. I said GLP-1, she's like 100% of the women gain the weight back, is what I got. And I don't know that I don't like synthetic medications, but I don't want to live like I was living. Hot flashes, night sweats, not sleeping, no energy. That's not life. So do you take the GLP for a period of time where you get back to your weight and then kind of go off of it and try to maintain that? Because this really sucks.
I think that's nuanced just as perimenopause is. And I think to piggyback what Ashley was saying, other things we can do to help support you is using our multidisciplinary team. So meeting with a registered dietitian, getting a basal metabolic rate, because what we see a lot too, we were taught, less calories, calories in versus calories out. But to sustain your metabolism, people come to me and they are starving themselves. Well, your metabolism is going to start shutting down. It's like an engine. You got to put that gas in there. So sometimes finding the right tools and knowing where to start can be really helpful as well when we're trying to recomposition our body. So, and protein, fiber, and definitely the strength training. That's going to just help drive your metabolism. It's so important. It's going to help prevent those fractures.
And can I pipe in, though, that we do not need 150 grams of protein a day? I hope you all agree with me on this. So this is like the big thing these days is everyone's like, I'm getting 120, 150. I need 180 grams of protein a day. So your body can only use so much protein. And then all you did was give it extra calories. So you need realistically about 20 to 30 grams of protein 3 times a day. And I want 25 grams of fiber at minimum. Fiber. Can we talk about more fiber? I could really care less about anything but fiber. That's going to do your gut microbiome. That's going to keep you fuller longer. Fiber actually creates your own natural GLP-1 in your body. So let's just use our own bodies and our own real food to do this work.
What do you suggest for that fiber? What do you think that's good?
So do you care if I take this or does somebody want to? Okay. So in general, so everyone, when we think fiber, everyone talks, well, I eat tons of vegetables. That's always what they tell me. So actually that's probably not your number one source of fiber. So yes, I totally want fruits and vegetables every single day, but actually your biggest sources of fiber are going to be the things that people quit eating. Grains, because everyone went on this weird keto diet, which is very atherogenic and actually increases plaque in the arteries of our heart and leads to heart attacks. Even if you lose weight on a keto diet, it is actually causing plaque buildup in your heart, probably based on all the evidence. So it's fruits, vegetables, it's whole grains. I want them all. Oatmeal, brown rice, quinoa, buckwheat, farro. If you've never heard of it, try it, okay? And then also it's your legumes, and this is your powerhouse. So it's your black beans, chickpeas, lentils, and then you could add all your nuts and seeds, flax seed, psyllium, chia seeds, pumpkin, walnut, almond, all the things.
How do you feel about a fiber supplement, like the Beta fiber in the water? Is that not the same?
Yeah, so
or I would think your body just sees it as fiber. Is that correct?
totally, for sure. Yeah. So I always say if you can get your fiber from food, let's do that first. But if we can't get enough fiber, if we can't get those 25 grams of fiber from our food, let's 100% add a Metamucil or a Benefiber or something like that. Psyllium fiber is really probably the most beneficial. So that's going to be your Metamucil. I don't remember what Benefiber technically is, but it's not a psyllium. But psyllium fiber is going to be the Metamucil. Obviously, that tastes like orange drink, which is not my personal favorite. But you can actually get the psyllium fiber in like raw natural form if you order it online. I dump it in oatmeal every morning. I mean, I'll tell you, my oatmeal in the morning is oatmeal, and it's plain oatmeal, and then I scoop flaxseed and I scoop psyllium fiber, and then I throw a whole bunch of berries on top and a little cinnamon, and welcome to fiber heaven. Yeah, do it. So
You can sneak fiber in everywhere. Put it in a smoothie. Put some in whatever little dessert you like to have. Chia seed pudding, 10 out of 10. It's so good, you guys. Do it with Greek yogurt, and then you get a little kick of protein too. You know, there's so many ways to sneak it in because people are like, ugh, flaxseed. No, but like if you put flaxseed in some oatmeal, you don't know it's there. If you blend it up with some fruits or whatever you like in a smoothie, you don't know it's there, but your body does.
you can make black bean burgers. I'm a firm believer of like adding black beans to everything.
With quinoa.
Everything.
Yes. What other questions do you all have? This is so good. I love this panel so much.
I have a question.
Yes.
I have always been against medication in general. I can't swallow a pill for the life of me. So I will avoid everything till the very last minute. But what I worry about is, am I potentially taking it too far where I'm dealing with my symptoms and pushing it to a point where I may be hurting myself in different ways by avoiding hormone replacement therapy and everything that I could possibly take. I don't know how to handle that kind of like barrier between, I don't even know how to bring it up with my provider. I've never taken, my husband took my pregnancy vitamins. I bought them and he said, we can't let these go to waste. So he ate them all. But sometimes I wonder, am I potentially endangering myself by just avoiding help, whether,
Anyone want to? Do you want to take this?
Effects to something like
Or do you want me to try? I can take it.
I always like to reframe it for my patients because I have a lot of patients who also come in from like a functional medicine space or an integrative health space where they're like, I want to do all this holistic stuff. I'm doing wild yam progesterone and I'm getting my estrogen from soy and whatever. And those things are fine. But the way that I like to frame it is that hormone therapy is not unnatural. We're giving your body back something it can't make on its own anymore. So it's not that, you are taking this medication and it's adding this, weird foreign thing. we're just doing what your ovaries can't do on their own anymore. And so what's more natural than giving your body the thing that it made for most of its life, you know? And then thinking about long-term health, we have to remember that a lot of hormone replacement, you know, the taboo was, you know, oh, it's going to be breast cancer, heart attacks, whatever. And now we know that a lot of it is actually the opposite, right? So mostly breast neutral unless you have other factors going on. For cardiovascular, it's super protective. We know that estrogen is one of the big drivers of maintaining the elasticity of your vasculature and also preventing atherosclerotic buildup inside of your arteries. We know that for women, you know, atherosclerosis and cardiovascular disease is going to present differently. That's why women having heart attacks present differently. They have more of the disease in the minor vessels than in the major vessels. And so, you know, when we're avoiding things like hormone replacement and just dealing with symptoms, in the short term, fine. If you can cope, that's great. But in the long term, you're doing yourself the disservice of having all of these long-term downstream effects of having long-term estrogen deficiency, like the bone density issue, like the cardiovascular issue. So I always want my patients to think about it more in the sense of what's more natural than doing what your body's been doing for most of its life, instead of the thought of, I'm taking this extra thing and cheating.
Can I take that though a little? I'm gonna play devil's advocate here.
Okay.
So I'm gonna say, and clearly I prescribe menopause hormone therapy every single stinking day, okay? So just know that. But I will say that menopause is a natural transition. It's not a disease, okay? So it doesn't have to be treated. If you choose not to treat your menopausal symptoms, you don't have to do that, okay? Whatever you choose is right for you. And remembering that, yes, if you are very symptomatic, I would recommend that you treat, because we know that when you have more symptoms, like the people who actually have more hot flashes and night sweats have more cardiovascular disease. Whether it's a direct correlation to elasticity in blood vessels and things like that, potentially, whether it is that when you're having night sweats, you're not sleeping, and we know that sleep is so foundational to prevention of disease, weight management, cardiovascular health, all of those things could be related to that too. But we do know for a fact that people who have more vasomotor symptoms, is what we call them, which is the combination of hot flashes and night sweats, have more cardiovascular disease. So if you are symptomatic, maybe we should think about treating this, and we can come up with a way that works for you and makes you feel great about your body, but you don't have to treat this. If you don't want to, you don't have to. Let's talk about how we can optimize your diet, your exercise, your strength training, your mental health, sleep hygiene, all of those things, and that's okay. I promise.
I have a question. So, like, my sister's got on estrogen patch and all this stuff. I'm like looking into it, but I'm curious, like, how do most people like continue on, like, for how long? And then, like, because I mean, if you start on having estrogen and your body gets used to that, like, how long do people usually stay on it? Do they keep doing it after menopause? I mean, how, like, I don't know. I'm just curious, like, what are the timelines with people and treatments and stuff like that in the long term? Like,
You haven't talked recently.
I know. Well, I feel like this is changing a little bit, because it used to be, okay, we're going to keep you on it for the shortest amount of time. And now women are coming and they're just like, please don't take this away from me. So I guess in my practice, I am individualizing it. I'm going to see how you're doing, how your symptoms managed, maybe look at your other risk factors. And we're having a discussion every year. I mean, at some point we probably will have to stop it, but I also feel like the research is changing and maybe we keep you on. I mean, you can be on the vaginal estrogen forever. I think everybody should be on vaginal estrogen. Yeah. I actually have started just outright asking all my patients about this now, where my practice has changed in the last several years. You know, used to be women coming to me and I'm kind of like, hey, and they're like, what? No one's ever talked to me about this. So I don't know what everybody else is doing as far as continuing the systemic hormones, but as of now, I just have a conversation every year when they're stable and check in and continue to assess symptoms, risk, and patient choice. And as long as they're informed about the benefits and risks, I want to improve their quality of life.
So as somebody that does not have a uterus or menstrual cycles anymore, how do I track where I am in the
process?
It's difficult to know, but you're the type of, how old, can I ask?
I'll be 46 next month.
You're 46, yeah. So, that is the challenge, right? So we always go like, oh, you haven't had a period, right? But you're that person.
I had a
You still have your ovaries?
Yes.
Yes? Okay, good. I'm glad you still had your ovaries and they didn't remove your ovaries, because we see women getting castrated essentially at very young ages, and then no one gives them hormones, and that's like the worst thing ever.
Or they don't know that they took their ovaries.
Yeah, that could happen. But for someone like you, again, it's a conversation, right? So we say those 3 hormones: estradiol, progesterone, testosterone. And the traditional thinking is for a person without a uterus that you don't need progesterone. Some people without a uterus will benefit from progesterone. But if you're symptomatic, it doesn't really matter. Again, I could check your hormones and I could say, your FSH is an estradiol or today look like they're in menopausal range. I'm not sure, but let's talk about your symptoms and let's talk about how we can help, you with those symptoms. And these are the things that we could talk about. And so I don't really need to know, right? If you're having estrogen deficiency symptoms, I would give you estradiol back, right? And even though you don't have your uterus anymore, if you're really having issues with poor sleep and stuff, I might even say you might benefit from micronized progesterone, because that, for some people, it affects GABA in our brains, which has a really calming, sedating effect, and you might benefit from that too. So, yeah. So, yes, hormones could be checked, but again, it's probably at 46 not going to impact what I'm going to offer to you. Yeah.
Yeah, I'm curious about if you touched on the testosterone piece, and that was something that piqued my interest in the documentary, that women are being prescribed kind of this off-label use of testosterone since there isn't an FDA-approved system. You all know I'm saying it's probably that right. But if I remember, there were some symptoms that it talked about that testosterone can be helpful with that I was like, like that piqued my. Is that something you all are prescribing or you're seeing? Is it too new? Is it something I should come to my provider with? Because I guess I am a little bit like, there's all these things happening. I want all the things. I'm not just working with the things. I need the things. So, I just would love to hear what you have to say.
Cool. So yes, I prescribe testosterone pretty much every day. So you are correct. There are 0 FDA formulations for testosterone for women in this country. Okay, there are a couple countries across the world that do actually have female dose testosterone, but the United States is not one of them. Okay, so the Menopause Society has had a statement that said in postmenopausal women with hypoactive sexual desire disorder, it is reasonable to trial testosterone therapy for these symptoms. Okay, so there were a couple different words that they used in there. So one is hypoactive sexual desire disorder. So what is that? So HSDD is low libido for 6 months or longer that is distressing to the patient, okay?
Not your husband or your partner.
Right. Distressing to you for at least 6 months of your life, okay? And that is all it is. It's a clinical diagnosis. If you meet the diagnosis, you can have that, okay? So testosterone therapy, really the only clinical evidence is in HSDD. So you will hear a lot of other things about, testosterone is going to help with my mood and my sleep and my energy and my muscle mass and cognition and all of these things. The evidence isn't strong enough to actually support the benefit in those other conditions. It is strong enough to support the benefit in HSDD. So that is primarily what I use testosterone for in patients that do have that. I also always say that there are 2 FDA-approved medications for HSDD. So I do make sure that as a clinician, I know the literature and I have to offer you the FDA-approved things too. So there's also Addyi and Vyleesi. Addyi is a pill that you you take one time a day at nighttime. It's the pink pill. So, we've moved on from Viagra. We're onto the pink pill. So this is Addie. You take it at nighttime. It helps with sleep anxiety, improves sexual satisfying encounters by about 1 encounter per week in the literature. And you drink alcohol with it. So you have to separate the alcohol from the medication for at least 2 hours before you can take it. And if you have 3 or more drinks in one day, you have to skip your Addie that night. Vyleesi is an injection that you'll do 45 to 60 minutes prior to sexual activity. So it's going to be a little bit more like your Viagra, where you're just going to use it on demand. It does have a little bit of a nausea side effect. So sometimes we will prescribe anti-nausea medications with it. But yes, so there are FDA-approved medications for HSDD, but yes, testosterone can be used for that purpose.
That result in your practice that people are happy with it, and are there negative?
Yeah, for sure. I have mixed. So I have some patients who absolutely love it and have told me that their sexual drive improved, as well as they felt like their clitoris was palpable again, and their orgasms were more orgasmic. I see a lot of those kinds of symptoms from it. I have some patients who try it for 3 to 6 months and say it didn't make a difference for me, and so they choose to stop it. I have a couple patients who have stopped it for side effects. Side effects are pretty mild. Had a couple patients complain of like increased vaginal discharge they didn't like, and then the other side effects that I always talk about are acne, hair growth on your face, or hair loss on your head. And then the big scary part, my big preach when I'm going to get on here about testosterone, is you have to do labs. I just told you that we didn't really need labs for most other things. Testosterone, it is not optional. If you do not do your labs, I will not prescribe you your medicine. You will not get refills. You will do your labs, okay? Because there are irreversible side effects if your lab gets too high and you are not doing this appropriately. So you can have deepening of the voice and enlargement of the clitoris. You basically grow a little miniature penis, okay? If you take this and you don't do it right, these are real things. As long as you take it the way it's prescribed to you, it's a wonderful drug with very few side effects and can be very helpful for sexual function. But I also should probably throw out there that HSDD, I did give you some of the criteria, it also requires an absence of another cause for your sexual dysfunction. So I know you had kind of hinted earlier in this about pain with intercourse. So we would actually want to fix the pain with intercourse before we would actually diagnose you with HSDD, because no one is going to want to have sex when it hurts, right? I cannot make you like to hammer your thumb over and over and over again, because that sucks, okay? But if I fix the pain and now all of a sudden the enjoyment comes back, well, then you never really had HSDD. You had dyspareunia associated with probably genitourinary syndrome of menopause, and we probably just needed to do some vaginal estrogen or something.
I think to your point, it's really important to recognize that, look at all these amazing providers who are here to help you, and so many people right now are just taking all this stuff into their own hands and increasing doses on stuff that they don't even know what the effects could be. I mean, there's so much happening online that people are just like, I don't need a doctor, I'm just doing my own thing. And it's overwhelming. It's like everything from how much protein we should be eating or whatever, what we should be giving up or adding, to actually changing doses for medication on their own. And like, this is serious stuff. So,
one thing I'll say with the testosterone as well, I mean, you'll see pellets marketed a lot. And I think I'm not a fan of pellets for reasons that Dr. Warner talked about. Once you get that pellet inserted, you are stuck with that dose for up to 3 months. And if you have irreversible side effects, you have undesirable side effects. So really, if you're thinking about doing testosterone, encourage you to have topicals and go to a provider who's experienced in prescribing that.
Yeah, because we're really wanting to get testosterone into just a physiologic range. And again, I've seen a number of even very young women, and I don't know, I'm not like a reality TV person, the housewives of who knows where, but they're all doing their pellets, and I think they're just putting on more makeup or something to cover up the acne and things because, they're getting themselves into really a super physiologic range. And there was this article in the New York Times number of 6 months ago or something, all about testosterone and how this is a thing. And these women are, like so happy with their sex lives. And they're like, but yeah, my hair's thinning and I'm growing hair, and I'm like, what are you people doing? This is crazy, crazy. So again, there can be a role for testosterone, but we just want to keep it physiologic. And yes, we only have testosterone. We're using 1/10 of the male dose for women when we do use it, but that's super important. And then, and don't be afraid to talk about sexual health with people. And us as physicians, we don't ask enough, and we need to talk about it more because I think this is something that women have suffered with, and it's, pain with intercourse, vaginal dryness, again, vaginal estradiol or DHEA for everyone. There's like, yeah, it's so helpful. And and sometimes it's just not, the vaginal estradiol may not be all that you need. If it's been a really long time, again, for older folks, and now those tissues have been constricted, you might need dilators. And some of my favorite people in the world are pelvic floor physical therapists. They are amazing people because sometimes you get something called vaginismus where it's like a trained response, right? It's Pavlovian, like it's going to hurt and I'm going to tense up. And then you get all this tension in your pelvic floor and things are just painful. And they work with you and it's a very hands-on, right? Doing myofascial release and trigger release and can really make a huge difference in women's lives when they've been suffering with painful intercourse for a long time. And we are also really great for pelvic pain and bladder issues and incontinence issues and all those kind of things.
Vaginal estrogen, the same as the patch?
No. So, and you can be, yes. So for some women, we talk about systemic hormones and then we talk about local or vaginal hormones. And it's really not vaginal. So so when we're using the way I most commonly, because I see a lot of women at Planned Parenthood who are low income or uninsured or underinsured. And some of these things are really darn expensive and out of reach for a lot of people, unfortunately. So when we talk about vaginal estrogen, vaginal cream is usually the least expensive. And it allows you to kind of titrate dosing a little bit and get it where you need it. There's tablets. There's a little suppository that you can place, and then there's a ring. There's two rings, actually. There's a ring
There is one ring that is systemic.
Yeah, so there's a systemic ring.
Caution here is
yes.
There is one vaginal product that
Fen ring, systemic, S-string, E-string, local. The cream, people talk about the cream being messy. Does anyone in the room use vaginal estradiol? Yeah. So they're always like, no one's going to like the cream because it's messy. And the cream comes with the inserter. And I just don't tell people to use the inserter, like chuck the inserter, right? Because if you just take the cream, put it in the inserter, insert it in your vagina and let it sit there, it's going to gooze out and be all messy. And you're going to have, it's like, what? But that's not how we moisturize any other part of our body, right? You just don't slap it on there and let it sit there. So, yes. So you're going to touch yourself, put it on your finger, and that lower, third of the vagina, that's where it usually hurts, and kind of put it in fingertip, and then take another fingertip, and then around the opening of the vagina, your vulva, around your clitoris and urethra area, and gently rub that in. So all those tissues need that local estrogen to stay healthy. So
I saw the question in the very back.
not that I feel passionate about vaginal estrogen.
Yay! Can't wait.
I want cream of estrogen. I don't think that's happening. I want that.
Well, ask your provider.
Yes.
We've got a couple more questions. Well, let's do these two, and then maybe I do want to make sure everybody knows that we have information about Planned Parenthood on our table. Everybody brought information back there, and I will leave us a couple minutes in case you want to run up and talk to people in person. But 2 more questions, and then I think we'll 3 more questions. Okay, 3 quick questions.
You said there were some exceptions to hormone therapy, and my doctor, when I talked to her about it, nurse practitioner, she said, "Oh, I don't like that for you, because I have a heart condition." Is that an exception to hormone replacement or hormone replacement therapy? Or
Are you willing to give us any more information?
of what kind of heart condition? I had stent split. I had like a. So
How-
I don't know. Like it's
How long ago?
3 years ago.
I'm going to let you take that one, primary care doctor.
So this one's going to be really nuanced, is the real answer. So this is going to be a thorough risk-benefit discussion. So the recommendation is you cannot do hormone therapy in active cardiovascular disease. So active being the key word here. Is 3 years ago having a stent active? I don't know. Do you have any continued chest pain or angina? Clearly that would count as active. You know, if you are stable on a statin, your LDL's at goal, you're on aspirin, and you are having symptoms of menopause and perimenopause that are really disruptive to your life, am I going to weigh the risks and benefits in this case and potentially say that I counseled you and you were aware that there is a possibility that this could be harmful? So again, when we look at this big study, when we talk about the cardiovascular risk, so the big Women's Health Initiative study, it showed an increased risk of cardiovascular disease. This is like the complete opposite of what we thought. We ran this study to prove that hormone therapy actually decreased cardiovascular disease, and then the complete opposite ended up happening. But the average age of woman in this trial was 62, okay? And so then this is where we've done these post hoc analyses where we've looked at this study in more detail. So people give the Women's Health Initiative trial a bad rap. It's a great study. We just have to look at it differently. So when they actually looked at the women between ages 50 and 59, they had this improvement in cardiovascular disease. So is it beneficial for you or not? If you're in the right age range, maybe. However, again, part of the theory is when you have not had cardiovascular disease, estrogen is beneficial and helps to prevent a cardiac event. When you have had a cardiac disease already, there's already plaque built up in that artery, it's possible that estrogen could actually have the opposite effect here, and it could be pro-atherogenic and could actually worsen your cardiovascular disease. So this is a super nuanced conversation. It's something that you're 100% going to need a specialist in this field to discuss, and it's not an easy answer.
I also was referred to you this week.
What time?
You just began the conversation.
I love it.
This is so great.
My question is not really a question, it's an experience. Like I had my annual a year ago, and I didn't really have any symptoms. My doctor says, as I'm in the stirrups, "Oh, I can see you're going through perimenopause," and I thought, pardon me, you can see some changes? Like, I didn't know that there was these physical, external changes to the tissue that was pointed out to me by someone, and I was mortified.
I guess I'm sorry that
Should
you
have
haven't.
been.
Yes, I think there's probably a more tactful way to
Like,
have that
just
conversation.
casual, and I was I was mortified. And you don't expect that there are physical, visible changes to something like that, like, acne, hair loss. And then I'm just like, do I need to ask my husband? Like, is this an issue? I don't know. It was just really something that I don't think people are prepared for.
Yeah, definitely. I don't really have a good response to that. Just because the experiences that I hear, when women come to us, with most of us, and like we hear these stories and the trauma and the help that you go through, it's no wonder why you don't want to go to your provider and tell them the symptoms that
It
you're
was
having.
literally a year after that where I finally thought.
And you're still thinking about it.
Yeah, oh, absolutely.
Tells everyone.
I think most importantly too, it's how you're feeling. You know, I think that sounds like that wasn't the greatest choice of words from that provider. But if you're feeling good, if you're not having symptoms, I wouldn't worry about it.
Last official question. So if you have an IUD already, does that affect like any kind of like treatment? Cause they ask about like, oh, is your period regular or whatever, but if you don't really like have it, it's hard to say. And then I know it's more localized, but would it affect like any of your options for treatments or anything? Like, I'm just curious.
It's awesome.
Yeah. What type of IUD, if you don't mind? The hormonal IUD? Yeah. So, and just the one thing that we always just bring up to remind people, because I also am an abortion provider, full disclosure, is I see a lot of midlife women, perimenopause, who are like, oh, I just thought I was too old to get pregnant. It's like, no. So, right. So, if you are having the type of sex that could lead to pregnancy, we're always like, if you don't want to become pregnant, do something to prevent that. I'm a huge fan of vasectomy, but IUDs are amazing and wonderful. And again, it's sometimes that thing that can mask, like, where am I in this journey, in this transition, into menopause? And again, if you're having symptoms, we're going to treat your symptoms. But again, for those folks with a uterus, right? We learned a long time ago, if we just give estrogen alone to women with a uterus, we're going to build up the lining of the uterus, and that could lead to uterine precancers and cancers, and that's not a good thing. And so anyone with a uterus who's using hormones, if they're using estrogen, they need something to provide what we call this uterine or endometrial protection to prevent endometrial cancer. And that's still, anytime you get estrogen, there's a big black box warning. They're modifying it now, finally, thank God. But even on vaginal estradiol, you're going to see uterine cancer warnings. It's just going to scare the bejesus out of you, vaginal estradiol, unless you're putting the whole tube in your vagina on a weekly basis, will not give you endometrial cancer. But systemic estradiol, you need endometrial protection. And we're talking about micronized progesterone a lot. Not everyone tolerates micronized progesterone. Some people love it. It's like this, warm, fuzzy blanket, and they go to bed and they think it's wonderful. But other people, they get GI issues and just, and for some people, especially with other mental health issues, it's not good for them. And so it's like, oh, we need a different progestin. A levonorgestrel IUD is a great way to provide that endometrial protection while we're giving you the other systemic estradiol. It's generally recommended, it's now FDA approved for 8 years to prevent pregnancy. The last that I have learned, is that it should, I just want to make sure we had consensus on the panel, that it should be changed every 5 years when you're using it as part of menopausal hormone therapy.
So
But-
essentially it's acting as your progestin.
Yeah, but it's your progestin locally. Yes, yep.
You can still do progesterone on top
And
of
you
it.
could even do, right. So
That's my kind of question too, though, is I have an ID, I'm on year 6, prescribed for pregnancy, but now the insurance won't cover it that I know of for perimenopause. It's only covered for pregnancy.
Oh, we
because
just tell
that's how it was
them
originally
Have abnormal bleeding.
you have abnormal uterine bleeding and it's changed.
We'll find a reason.
Again,
It looks kind of low lying.
All right, y'all. I know that we could keep talking probably for another hour. This is so awesome. Who I want to thank is all of you for being here and doing such a great, having such a great conversation with us. And also, what an amazing panel of local experts. Wow. I know that I learned so much and have more questions and ideas and thoughts, and this is so cool. I love being in a space like this where we're like laughing at the wild things that happen that really aren't that funny. But when you find community of in a space like this where we're going through the same things, hearing the same things, and finally going, "What the hell? Why did my provider say this thing to me?" But then to see all these people up here who are like, no, it doesn't have to be like that. I feel really great. I feel excited. I feel really hopeful about what's happening in this space. If we didn't answer your question, I'm not sure we answered the billing question back there or everything. Like, just come up and keep chatting, get information on the table. Come see us at Planned Parenthood. You've got a bunch of new patients that you're going to see. Make sure you have all these people's information. They have ways you can get a hold of them. So, yeah, we're all going to be here to answer some questions. I'm just going to make them take a selfie with me, and then they'll be yours to talk to. Thank you all so, so much. Thank you to the library.